Thank you very much. This is one of the difficult topics to summarize all the trials in implantable defibrillator pacemaker in patient with heart failure. So I would like to start with this slide. So basically, looking historically into the number of ICD implantation going back to 1980s. This was the first human implantable defibrillator was implanted. The FDA approved this therapy in 1985. The first, prior to that, the leads were epicardial. In 1989, it was the first transvenous biphasic waveform leads, or the unipolar leads. In 1993, the devices and the technology became smaller. Initially, they used to be implanted in the abdominal cavity and then in the upper part of the chest once the devices are becoming of a smaller size. And as you could see here, the number of implants started to go up dramatically after the first landmark trial, which is the MADIT one in 1996, followed by AVID, CASH, MUST, MADIT 2, and this SCUD-HEFT. The number of implantable defibrillator varies from one country to another. And basically, we know that defibrillator and CRT do save lives. ICDs reduces the risk for sudden death, but do not modify the disease progression. And this is a myth. In fact, many of the physicians thinks once we implant a defibrillator, the patient will not have a ventricular tachycardia anymore. But this is not true. The defibrillator, they just try to stop if a ventricular arrhythmia from happening. So regarding CRT, they modify the disease progression, but do they reduce risk of sudden death? This is still controversial, and I will be discussing this during my presentation. So just for the audience here, regarding the trials, basically they were looking into different populations. So looking at secondary prevention and the primary prevention population. So what is, just to outline, secondary prevention is the prevention after a prior life-threatening arrhythmic event, and the probability of a second event happening is quite high, and that's why implantable defibrillator is important in this group of patients. Well, the second group is, we call it, in the primary prevention group, is to avoid any severe cardiac arrhythmic event from happening for the first time. So it is a preventive measures. So this is a very important slide which you see in almost any heart failure presentation. And this was published in Circulation in 1992. Most of the defibrillator trials basically are involving the high-risk group with ejection fraction less than 30%, cardiac arrest survival, post-MI patients. Whereas what we are experiencing, basically most of the cardiac arrest event are happening in this group of population with a low incidence of the disease. So there is a lot of work needs to be done targeting this group of patients. So, but up to now, until now, the reduced ejection fraction remains the single most important risk factor for overall mortality and sudden cardiac death. What is the underlying arrhythmias of sudden cardiac arrest in patients with heart failure? More than 80% are due to ventricular tachyarrhythmias, and 17% are due to bradyarrhythmias. So what is the importance of early defibrillation? It is extremely important. The earlier you defibrillate, the higher success rate of recovery, and the chance success decreased by 10% per each minute. So this is an extremely important to understand. In the United States, they say to the patients who are at risk of sudden death or arrhythmic event, the most safest places to be is number one in the electrophysiology lab, and number two is being in Vegas. And the reason for that, there is a lot of cameras all over, so any event happen, it will be picked up almost immediately, and there is plenty of external defibrillators around, and the patient is the likelihood of successful resuscitation is quite high. So, okay, so let's go to what are the major trials for prevention of sudden cardiac death. I would like to summarize some of the important ones. The one in greens are in the primary prevention group, and the one in yellow are the secondary prevention group. So the first landmark trial was MEDIT-1. It was in 1996, recruiting 196 patients with ejection fraction of below 35%. It was a bit complex and tedious. A patient should have an unsustained VT. They need to go to the EP study. They should be inducible. And then they are randomized to an ICD arm versus medical therapy. And this was significantly positive with mortality reduction in the ICD group. Then basically we go to the MEDIT-2. This is, they're trying to make things more simple, was published in 2002, recruiting 1,200 patients with ejection fraction of less than 30%. And the only thing is just a prior myocardial infarction. The hazard ratio was 0.69, and it was a significant p-value with a mortality reduction in the ICD group. Up to 100 patients had a defibrillator. 30 of them, they had a successful or an event, and they were successfully resuscitated by the device. This one, the cabbage patch, it was published in 1997, recruiting 900 patients. Here they were, the lesson here, they were trying to look at patient post-cabbage who had severe LV dysfunction, and they have positive signal average ECG. So they randomized them into an ICD arm and medical treatment arm. Basically, this study was negative. They have shown that post-cabbage ICD or post-revascularization cabbage, they did not show a mortality benefit among the two groups, so the study was stopped. So in this group of patients, probably medical treatment is a good enough options. They looked at the non-ischemic cardiomyopathy in the definite, and this was published in 2004. Ejection fraction was also low, below 36%, and it was basically, they say that if one patient died in this, it would have turned positive, but it was having a trend toward beneficial effect. But we all know that the ischemic, they do better than the dilated or non-ischemic cardiomyopathy regarding the defibrillation. Looking at dynamite, so dynamite, it was published in 2004, looking at 600 patients, and they target immediately post-acute myocardial infarction, 60 to 40 days. So they found this also was negative trial, and in fact, they did not show, so there were no benefit of implanting a defibrillator early post-myocardial infarction. Patients were dying, but maybe from other causes like rupture, mechanical causes, but not of an arrhythmic cause. So SCAD-HEFT, I will mention it later on. Regarding the secondary prevention trials, we have AVIL, which showed statistically significant. a history of prior arrest or unstable ventricular tachycardia with ejection fraction of less or equal to 40%. The other two studies were negative. So another question always comes, and people ask, is antiarrhythmic medication are effective in preventing sudden death compared to the defibrillator? And the answer is no. Antiarrhythmic drugs has no role, and still defibrillator is the standard of care. The SCUD this is one of the landmark trial. Maybe I will spend a little bit time here. The inclusion criteria: heart failure more than 3 months, ejection fraction of less than 35. They included both ischemic and non-ischemic, and they took a population of New York class 2 to 3, and they were on ACE inhibitor for more than 3 months. They excluded the class 1, New York class 1 to 4, asymptomatic patient with ejection fraction, also they've been excluded, and the ejection fraction above 35 been excluded. History of cardiac arrest also they been excluded from this trial. So they randomized them into 3 arms, placebo and amiodarone and single chamber ICD, and it was mortality by intention to treat analysis. There was a significant mortality ICD therapy versus placebo with a significant p-value. There were no difference amio versus placebo. In this study, they also looked in the 2 different populations of ischemic etiology versus non-ischemic etiology. It was significantly significant in the ischemic etiology compared to the non-ischemic etiology. And the New York class 2 patient did better than class 3. So let's switch gear here and go to the next type of modalities. It is the cardiac resynchronization therapy. And the Rationale patients with severe LV dysfunction, left bundle branch block, they have the reason for their symptoms are due to dysynchrony. There is atrioventricular dysynchrony, there is interventricular dysynchrony, and there is intraventricular dysynchrony. So for that reason, the CRT is quite helpful, or in this group of patients, we implant an atrial lead in the RV septum and in the coronary sinus, and this is the left bundle branch block. So what are the CRT trials in heart failure? They have divided them into 2 groups. One is the sicker symptomatic group, New York class 3 to 4, and they were all of them as seen here, patch, CHF, Mustec, Miracle, Companion, and Care HF. The QRS duration was more than 150, 160 milliseconds, and the rejection fraction is below 25%. I will concentrate on the Companion and Care HF. So the CRT patient with the New York class 3 and 4, basically there were 3 arms here. There is the medical therapy arm. There is CRT-P, means P stands for pacemaker, and CRT-D stands for defibrillator. So they were trying to see which one is. So here it showed both. They were efficacious with a mortality reduction of 20% in the primary endpoint. In the secondary endpoint, there were also reduction. However, if we look at the CRT-P, the line first was along with medical therapy, and then after 1.5 to 2 years, it started to show a significant effect, and this was attributed probably to a effect of remodeling of CRT on the LV function as time progressed. The Care HF, they also targeted New York class 3 and 4 patients, and this was a pacemaker CRT-P basically. It's not a defibrillator, and it did show mortality benefit. However, again, the same thing here. So the curve started to diverge later on. So time is important in with the CRT pacemaker. So, and then the next question came here, whether a CRT is beneficial in less symptomatic patients. So they were looking at patients in New York Class 1 and 2, and there were several of these studies, contact, medical ICD, reverse, MADIT CRT, and draft. And I will maybe discuss the last two. And they were including quite large number of patients, 1,800, and they were targeting New York Class 1 and 2, and here is 2 and 3. QRS here, it is less wide, like 130 and more, and ejection fraction of less than 30. So looking at the MADIT CRT, it was 2-arm CRT, ICD, and ICD alone, and definitely showed the CRT mortality, heart death, heart failure by 34%. So this was the preferred therapy with a significant p-value. Also looking at the one in white is the ICD, and the red is the CRT ICD. We have observed 15 ml versus 52 ml decrease from baseline in left ventricular in diastolic volume, and the same thing in left ventricular in systolic volume, as well as improvement in the left ventricular ejection fraction with significant p-value in all of them. So in MADIT CRT, they looked, it is very important which group of patients we should target. So they looked at typical left bundle compared to the without left bundle, like right bundle or interventricular conduction delay. And in fact, the one with typical left bundle, they are better responders than the one without or atypical left bundle branch block. Regarding graft, I was one of the fellows with Professor Tony Tang at the Ottawa Heart in recruiting patients in this studies. So they were looking at patient, here is 2 and 3. Again, it showed there is a benefit of ICD-CRT compared to ICD. So the current guidelines, basically, they look at New York Class 2 to 4 on optimal medical therapy with ejection fraction of less than 35 and QRS width of equal or more than 150 millisecond, presence of left bundle branch block, and normal sinus rhythm. However, we are really encountered this, maybe 30% are fulfilled into that group. What about the other patients that they are in New York Class 3, they are having narrow QRS, they are symptomatic in spite of being on optimal medical therapy. There is a promising therapy now they are talking about. It is called cardiac contractility modulation therapy in advanced systolic heart failure. Basically, this is modulation is the application of non-excitatory electrical signal to the myocardium during the absolute refractory period of the action potential to elicit a positive ionotropic effect without increasing myocardial oxygen consumption. So this, they included a small number of patients in these studies. In fact, the earlier result, there is a benefit regarding quality of life and exercise tolerance, but there will be more study to look at mortality and hospitalization. But really, this is apparently a promising therapy. And as Professor Miller spoke about VO2 consumption, again, this work on the same principle. They compare, there is a smaller study looking at CCM including patients with normal QRS and wide QRS, looking at comparing the trial, they have done it compared to the CRT trials, and they are very comparable regarding VO2 max. So the probable hypothesis here is this is quite, so if the patient present with heart failure, you look for CRT indication. If they are candidate, you go directly to CRT. If they are not, you look at the ejection fraction. If the ejection fraction is below 35%, then the recommendation is you go for ICD alone plus implantable CCM, and this is how the device looks like. It has got a 3-port. One goes to the atrium, one goes to the RV apex, and the other one is RV mid-septum. So if patients have ejection fraction more than 35, they are qualified for CCM alone, and they don't need the ICD arm. The common patient that may benefit from this is New York class 3, normal QRS. Ejection fraction has to be above 20, peak VO2 more than 10 milligram per kg per minute. Ventricular ectopy or biogenin has to be less than 10,000 per day. So in conclusion, heart failure is a complex syndrome with a high morbidity and mortality. ICDs are effective in the prevention of sudden cardiac death. CRT induce reverse remodeling linked to reduction in the heart failure-related hospitalization and death, and possibly over time, sudden death as per CARE HF trial. Reverse remodeling evolves over time, and it takes 1.5 to 2 years to occur. Sudden cardiac death still exists even from day one, and that's why if you have a chance between CRTP or CRTD, you tend to choose CRTD because the CRTP takes longer time for the remodeling, and the cardiac contractility modulation is a promising therapy in symptomatic heart failure patient with ejection fraction more than 20. In patients are not candidate for CRT. Thank you very much for listening.